Today we have the great honor and the great pleasure to have Marleen de Bruijn as a keynote speaker. Marleen is one of the influential people in the community of medical image analysis and machine learning that I think has had a more transformational effect in the community. I think she has been there in key transformations of the community towards deep learning, towards machine learning, towards different types of paradigms, let's say, of analyzing data. She is not only a professor, a full professor of AI, she's two. So she's a full professor at Erasmus Medical Center in Netherlands and at the University of Copenhagen in Denmark. She has a PhD and a master's in physics from the University of Utrecht in Netherlands. And well, like I said, she has been one of the key people in organizing some of the biggest events and conferences in the fields. Like she has been program chair of MICAI, Middle, etc. So other conferences and IEEE committees, etc. that are very, very influential. Today she will talk to us about small data sets, weak labels, and adversaries within the idea of machine learning for medical imaging. So all you guys that are mechanistic, you know who you are. You always say, well, machine learning, you always need a lot of data, billions, trillions, quadrillions of annotated data sets. And Marleen is going to tell us how you do the black magic to actually work with the few data sets that you have available that are incomplete, that don't have labels, that are, or even without any data, right? So without further ado, I will pass the word to Marleen, please.
Thank you for that very kind introduction. And yeah, I apologize for not being there in person. That would have been nicer for all of us, I think. But I'm very happy for the opportunity to still give this talk in this way. So using deep learning, we can now solve many challenging medical image analysis tasks as good as human observers can. And here is just on this slide one example from work in my group. And what you see here are intracranial calcifications. They are calcifications inside the main arteries in the brain, and it's a CT image. And it's important to quantify these calcifications because they are a strong risk factor for stroke. And this used to be really quite difficult because the calcifications, you can't easily model their shape. Their shape is very variable. They are the same intensity as the bone that they are very close to, and sometimes they even seem connected to the bone. So before machine learning, or without machine learning, I think we wouldn't have been able to solve this problem. Here you can see the result of a simple convolutional neural network with the manual annotations in blue and the automated annotations in red. And you see a very good agreement between manual and automated scores. And if we had a second observer look at these images, they actually had a slight preference for the automated scores. This is just one example. We have seen in the past years many examples in which deep learning performs as good as, or perhaps even better than humans. And much more than before, we now also see automated image analysis based on machine learning making it into the clinic, and the number of approved products for this is increasing rapidly, as you can see here with the number of FDA cleared products in the past few years. Now, what do clinicians think about these developments? I do think we have a few MDs maybe in the room as well, so maybe we can discuss about this later as well. Here's some results of recent surveys among radiologists in the US, and another survey done in Europe found fairly similar numbers. At that time, 30% of respondents use AI in some form already. 20% plan to purchase a tool and start using AI in the next few years. And there may be a response bias here. I would have expected these numbers to be a little lower. I'm not sure about that, but still, was quite happy to see these results. Overall experience was positive. The accuracy of the AI systems was found to be good and the tools were useful. I'm not sure if you can now see my full slide because there's a lot of stuff on top of it on my side. However, a problem is that performance was inconsistent. The current models are not robust enough. They don't generalize well to all kinds of samples. Also, and probably because of that, there's little trust in autonomous AI systems. And if we want to improve generalization of our models so that they work on all kinds of data, of course, the first point to look at is if we can increase our training data. As a rule, so I think so you were promised that I was going to talk about very small data sets. First, to give some perspective, as a rule of thumb, Goodfellow and co-authors in their deep learning book state that acceptable performance requires about 5,000 labeled samples per class. And to match or exceed human performance, we will need at least 10 million samples. And I think this is far too pessimistic. In medical imaging, we have seen excellent results with much fewer samples. Especially in segmentation. In image segmentation, if you do good data augmentations, treat your data well, sometimes you can have quite nice results with just 10 or 20 training images, even in 3D images. But if we go back to this example, the intracranial calcifications that I showed you earlier, this model was trained on 1,000 images, and it does perform on par with expert observers. But we also see that we make more errors in the more rare cases, which are the larger calcifications. And also when we applied this model to data from another hospital, the results are not as good. They are still reasonable. CT is fairly standardized, but the results clearly deteriorate if we apply it to data made with another scanner. But of course, in principle, a lot of data is available to train our medical image analysis models on. We make many, many thousands of scans every day. For instance, in OECD countries, on average, every person receives one CT or MRI scan every 4 years, and ultrasound and X-ray exams are even much more frequent. But there are logistic and privacy issues in using and sharing medical data. We need medical experts to annotate these images, which is difficult to arrange, and it's expensive in experts' time. And in some cases, for instance, when labels are determined by biopsy, it is even more difficult or impossible to collect large and representative data sets. So even though medical imaging is fairly well standardized compared to many computer vision tasks, all humans have similar anatomy and are put in a similar way in similar scanners, scan appearance may still vary quite a bit between centers, between scanner models, between scan protocols. Here you see a few examples of what it can look like. On the top for brain MRI, these were different scans, all made for the same purpose of analyzing the brain tissue. So they are, for a radiologist, these are very similar scans. For our models, they look very different, and results are probably not very good when you train on one of these types of images and apply it to the other type. On the bottom row, you see the carotid artery. It's the artery in the neck, where you see here each row is a complete scan protocol, and this was actually a large multi-center study where these scan protocols were as much aligned as possible. So the radiologists of the different studies sat together in many meetings to try to make their protocols as similar as possible. But still you see quite large results in visual, large differences in visual appearance between these two types of scan. So of course there's a problem with domain shift when we want to analyze new data that is different from all our training data, but also if there are hidden correlations, if we have a very large and heterogeneous data set, but there may be hidden correlations between scanner model and disease, for instance, because the more difficult cases go to larger hospitals or the larger academic hospitals. And this is actually quite common. For instance, yeah, I actually already mentioned that. So apart from scanner models, there may be other confounders. Here's an example. In 2017, Nature published a paper showing that an AI model trained to classify images of skin lesions as benign lesions or malignant skin cancers. This model was trained on more than 100,000 skin images, and it achieved the same accuracy as board-certified dermatologists. And this spurred a lot of discussion to what extent these results were realistic and could they be transferred to other data sets. And one possible problem was that the algorithm had learned that if there's a ruler in the image, it is more likely to be cancer, because dermatologists typically use the ruler when they find something really suspicious. But that, of course, will lead to problems when we apply this to data from another center that uses the ruler less, or perhaps doesn't use the ruler, because they now rely on the AI system. And I'm not sure if you see the movie. There are also differences between patient populations. Here you see, for example, how brain changes with age, and models trained on data from older patients may not be suitable for younger subjects. We see especially the ventricles increasing a lot during this time frame. So in practice, medical imaging is always, I would argue, a small sample size domain, even if we have seemingly quite large data sets, large for our standards, hundreds or thousands of images. So the question that my group and many others ask ourselves is, how can we learn reliable models with less data? For me, that means moving away from brute force learning and see what prior knowledge we have that maybe help us to get the right solution. We will see that in many cases, it still helps to combine learning with prior knowledge, such as shape, smoothness, or consistency constraints that we often used before deep learning models became very successful. First, I'd like to show two generic approaches that we found useful in many situations. The first is to combine a convolutional neural network image segmentation with a conditional random field, a more traditional approach to segmentation. And these are then optimized jointly. So the CRF uses features that are learned by the network, and at the same time, it helps drive which features are learned. So the CRF then encodes our knowledge that neighboring voxels, as well as voxels that are far apart but look very similar, they are more likely to belong to the same class. Our baseline network is a UNet. It has a large receptive field, so in principle it could learn this same long-range information, but in the CRF it is more explicit, and that seems to help. We see that the CRF improves segmentation in all three applications that we have looked at. So here you see on the right the three applications that we tested. It's segmenting the aorta and pulmonary artery in CT scans without contrast. White matter hyperintensity segmentation in brain MRI, and also brain MRI stroke lesion segmentation. So quite problems with quite different properties, and in all these cases, the combination of CRF and CNN worked better, especially in small training set sizes. Another generally helpful approach is to ensure that predictions are stable over small image perturbations. And This can be useful as a regularization on any data, but it is especially valuable in the semi-supervised setting, where we also have unlabeled data that we can use for this. We found that this label consistency loss, so the loss is shown here in this figure. What we do here is we have a Siamese network architecture, an image and a slightly perturbed version of that same image are both fed through a network. They result in a segmentation. We have the regular supervised loss, which measures how good this segmentation, how well it compares to the manual annotation. But we also have an additional consistency loss that measures the consistency between these two segmentations. Once they are, so the perturbation in this case was a deformable transformation, and once they are transformed back to the original space, these segmentations should be identical. And we found that this label consistency loss improves segmentation, especially in smaller samples and when additional unlabeled data is used. And you may know similar mean teacher approaches. They actually assume that the current pseudo labels for voxel-wise supervision they assume that those labels are pseudo labels. The intermediate segmentations are correct. So there's a risk of propagating errors, whereas on the other hand, the Siamese architecture used here only enforces equivariance and does not propagate errors. Here the results in a little bit more detail. We see here in this table, we see segmentation overlap, the intersection over the union, and from left to right, increasing sizes of training set. The first row shows the standard supervised loss, or when we optimize the standard supervised loss, which in this case was cross entropy. And the second row shows that same loss, but added the consistency loss. And you see that even for fully supervised segmentation, so the column on the left, we train on only 5 annotated images, we see still a small improvement using this additional regularization, especially for small training sets. Now, if we also add unlabeled data, which we can typically obtain for free, manual annotations are time consuming to make and it can be difficult to obtain, but often it's much easier to get access to similar data from the similar population, similar scanners, but without annotations. So such unlabeled data can be used also, so we don't have the supervised loss, only the consistency loss terms. And if we add such unlabeled data in addition, we see a large increase in performance, especially when the training set is small. Now, another possible solution to better use the data that is available is to learn to train reliable models from so-called weak labels. And weak labels in different parts of the literature may mean slightly different things. What I mean here is weak labels are any label that contains less information than the label you want to predict. Typically, weak labels are easier to obtain. So for instance, if you consider the example of quantifying white matter hyperintensity in brain MRI, a strong label would be a radiologist indicates for every single voxel in this image whether it's a hyperintensity or not. Whereas weak labels, it could be many different things, but often it's a radiology report which would indicate that this subject has a moderate lesion load, or just that white matter hyperintensities are present, or perhaps the number of lesions that are visible in a certain slice. Now, if we can train our models on this, and oh, maybe I should reiterate, what I mean by weak labels is labels that provide less information than what you want to predict. So if we are predicting lesion load, or if we are, let's say, if we are predicting the number of lesions, then that would be a strong label. If we predict the number of lesions and at the same time, if we optimize based on the number of lesions, but at the same time obtain a segmentation of this image, then it's a weak label. So if we can learn reliable models this way, we can learn from a lot of data that is already available. For instance, in clinical studies, semi-quantitative analyses are often already performed by experts. There are radiology reports available made for many thousands of images on a daily basis. And there could be clinical databases with patient outcome that we can use for learning as well. I'd want to show you a couple of examples. First one is assessing the risk of stroke. And for this, we will analyze images of the carotid artery, the artery in the neck. And what in this artery, plaques, blood clots can appear, and that is dangerous because they may get loose and then travel to the brain and block an artery in the brain. So most important to know for the degree, and that blockage is a stroke, an ischemic stroke. So most important to know to predict the risk of stroke is probably the degree of stenosis, the degree of narrowing of the vessel lumen, but also the shape of the vessel, the shape of the plaque, and the components inside the plaque can help in the prediction. Components meaning, is there calcification which might stabilize the plaque a little, or is there more a lipid core or hemorrhage that could be signs of a less stable plaque. Models already exist that can learn to segment based on voxel-wise annotations. And here you see an example of MRI images and the voxel-wise segmentations of the vessel wall and different plaque components. But these voxel-wise annotations would have to be made specifically for model building. They're not made clinically. And therefore, they may be difficult to obtain. It's time-consuming, expensive to obtain. On the other hand, we have clinical annotations that are made for nearly any patient to assess the degree of stenosis, and they are more limited. They typically measure just the maximum diameter in different regions of the blood vessel. So we wanted to train a segmentation model based on only these clinically available diameter annotations. And the problem is that to optimize this, we need to be able to derive the maximum diameter from a shape in a differentiable manner. Now, our CNN gives us a probability map, such as we see here on the left, and summing the coordinates in this probability map weighted. So summing the coordinates weighted by the probability gives us an estimate of the center of mass of this shape. And then in different directions from the center of mass, we shoot rays with a Gaussian profile around them. And again, a weighted map. We make a map of distances to the centroid. Multiplying these three and integrating gives an estimate of the radius in that direction. And doing that for all angles gives us the full shape. And we can then compute the maximum diameter from the collection of boundary points, and that is that we use to supervise our model, to optimize our model. And this model can then segment any star-shaped object and has a preference for circular or piecewise circular shapes. And here are some results for different patients, with the ground truth overlaid here in the second column. So on the left, the original image, here the ground truth, and here our proposed weakly supervised segmentation, which is actually performs fairly similar to a fully supervised voxel-wise segmentation, and much better than other weakly supervised alternatives. So of course, these results are not quite as good as full supervision, but they do come quite close at a fraction of the annotation time required for full supervision. The next example I'd like to show is in learning imaging biomarkers of dementia. Now, our collaborators were interested in a quite specific marker of vascular dementia, which is also important in the risk of stroke and probably many other factors. We are looking at MS, for instance, as well, and it has been studied in sleep studies as well. We wanted to quantify enlarged perivascular spaces, which are fluid-filled spaces around the small vessels in the brain. And they are an emerging biomarker for, among others, dementia. And here you see what these lesions look like. They are very small, bright, elongated structures on MRI T2 images. And dark, but still elongated and long on T1 images. So I have selected a few examples here, where you see images with no enlarged perivascular spaces on the left, and with many of them, of which I have indicated a few with blue arrows. I hope you can see them on the right. Now, manual annotation of these lesions is extremely time-consuming, mostly because there are so many. In large lesion load, it can be an hour or more for a single slice, and then there are many slices through a brain in an MRI. So that's almost undoable to segment, to perform full annotation for these images. On the other hand, what is currently often done in clinical studies is to perform visual scoring. And there are different schemes for this. Our collaborators and many others use, they select specific regions in the brain. In most regions, they look at only a single slice and then count the number of lesions that you find in this slice. So what we wanted to do is initially to reproduce this visual scoring. Note that in this case, it's not really weakly labeled learning, I would say. If we just predict the lesion number, we get a valuable biomarker to use in clinical studies, but it's not weakly labeled learning. But we come to that later. So first, a 3D convolutional neural network to predict this number. Now, what we did is we use a network with pooling operators, like a UNet, so that we can afford to have a deeper three-dimensional network. But we also upsample to the original resolution towards the end. So here we actually have a hidden layer that gives us the attention of the network at full resolution. And then we sum that to give our output, which is the predicted number of lesions. So here is where the weak supervision comes in. Our model is optimized on just the number of lesions, but it provides us also the attention, a segmentation map for the lesions. And this model has very good agreement with expert scores. So the performance is similar to inter-observer agreement, as you can see here in this table on the left. And on the right, you see the associations with risk factors. So here you see the visual scores on the top and the automated scores on the bottom as a function of age. And we see that these associations are very similar for automated and visual scores, not just for age, but for other risk factors as well. This method was also, the automated method was much more reproducible than observers when applied to new images from the same patient, taken a few months later. And what you see here is the performance of a model trained on 1600 scans, so a pretty large data set. But these are labels that were already readily available from previous clinical studies. If we train the model on 400 images, performance is a little bit worse, but still good. If we go much lower, performance get significantly worse. So with around 100 images, just training on the number of lesions per slice, we couldn't get a good result anymore. So we need our labels are much easier to obtain, but we do need more data typically to train reliable models with weak labels. Now, what has the network really learned? So far, we basically only know that we have found something that correlates well with visual scoring. And if we look at the attention maps, so here you see the attention maps for different regions, and on the left you see annotated lesions by an expert observer. You see that by and large, the network has focused on the right lesions. It found evidence for perivascular spaces in the locations that were annotated by the observer. And in some cases, for instance, in the top left image, you see there are many more detections. So if there, I do hear some sound from the audience. If there are questions, please let me know, but I probably don't hear all of you. In some cases, so in the top left, we see that there are many more detections by the network than what the expert has indicated. Looking at these detections closer, we found that these are actually enlarged perivascular spaces. They are still perivascular spaces. They are slightly enlarged, just slightly less than the threshold for annotating them, which I think was if they are more than 2 millimeter in diameter. So our attention map performs quite well. The network seems to focus on the correct lesions. There are a number of other checks you can do. What we did also was remove some of the lesions and in-paint them with the surrounding intensity, and then apply our model to that image and check the output. And we see that with every lesion that we remove, the output does become smaller. Our predicted number of lesions becomes smaller. So of note here is that with every lesion we remove, our predicted count does not go down by 1, it goes down by less. So our model has detected lesions actually, so it's trained on the number of lesions in a single slice. It detects lesions throughout the image and then combines them to something that is quite closely predicted to the number of lesions in that single slice. But it actually, oh, sorry about that. So it does give you, compared to the initial annotations, it does give you whole region information instead of single slice, and in a quite reliable manner. And then finally, we've looked at the overlap between the enlarged perivascular spaces and possible other lesions, white matter hyperintensities, and lacunes, which could look similar. And even with the very limited information that our model got, but it got it in a very large data set, we found that this model could actually, to a large extent, discriminate between these lesions, even just using one MRI sequence, only the T2 image as input. So we think that this model could replace visual assessment in large studies. So that's what it already has been used for in several different studies since we did this work. But more than that, it also has the potential to improve on visual assessment because it uses full three-dimensional information. It gives you, it measures lesions throughout the volume rather than just this single slice. So it could be a more reliable marker. And based on the attention map, we could also quantify the shape and the volume of the lesions, which might be even more important, but they're less easy to quantify visually. But you may be able to quantify that reliably, even without a voxel-wise ground truth. All right, one more example, learning imaging biomarkers of COPD, chronic obstructive pulmonary disease. So first, some background on that. COPD is one of the leading causes of death worldwide. Early stages are severely underdiagnosed. There is no cure, but proper disease management can slow down disease progression. So we want to be able to detect it, and preferably in an early stage. The mechanisms involved in COPD are not well understood. Why do some get it? Some patients get it while others don't. We do know that smoking is a factor, but also on the other hand, there are non-smokers who get it, while some smokers can smoke until they're 100 without much issues. There appear to be different phenotypes that progress faster or slower and may require different treatment, but we don't really know what discriminates them. So we want to better understand the underlying causes, detect subtypes of the disease, recognize abnormalities early, measure the effect of therapy, predict disease progression. And for all that, we need quantitative analysis. And the current standard for quantifying COPD and emphysema, its main component is a lung function test. As you see here, a patient blows in a tube, you measure how much air comes out. So with this, you can only measure obstruction, but it's the gold standard for quantifying COPD. It's not very sensitive. You can only measure obstruction, so you can't really measure emphysema this way, but more problems that come with it, airway obstruction. You definitely can't measure where in the lungs the disease is, and you can't see it very early. You need to have quite a large destruction of lung tissue before you can actually measure it in lung function. If we do imaging, the standard for quantifying emphysema is based on CT density values. So we simply measure the relative volume of lung tissue that is below a certain Hounsfield unit threshold. However, we know that there are different patterns of emphysema. You see a couple of examples here on this slide, and we can't distinguish them with simple densitometry, just looking at the Hounsfield unit, at the CT numbers of these images. Here you see 3 different CT patterns, and they would all have identical densitometry values if you just look at the relative area below the threshold. So we want to do better than that. Now, quantifying patterns and severity of emphysema can be done visually. Here you see an example of an often used visual scoring system, which indicates the percentage of the affected lung tissue per region. And this is much weaker information than we would get from manual annotations of emphysema regions, but still provides relevant information. It's still really time consuming, and there's a large variation between observers. So this is not done standard in clinical practice, but it is done in some large clinical studies. For instance, in the Danish lung cancer screening trial, where we have access to the data. So to learn an emphysema prediction model from these visual scorings, what we do is, again, we train a network to reproduce these scores. And again, we introduce an intermediate segmentation label, a segmentation layer with the right proportions. And then with our weak supervision that gives only the percentage of affected tissue, we make sure that that intermediate segmentation image has the right proportions of emphysema, which regularizes the solution and gives a segmentation as well. Now, looking in a little bit more detail, this is the scoring system that is used. We divide the lung fields in 3D in 3 regions, roughly upper, middle, and lower parts of the lungs. And then the radiologists score in 6 categories, whether there is no emphysema at all, or what is the estimated extent of emphysema. So what is the percentage of lung tissue that is affected by emphysema in this region? So we have percentage intervals as labels. So we constructed a loss function that reflects that. So remember, we have 6 categories, and therefore our loss is based on a sum of 5 gross entropy losses. The first component of the loss enforces discrimination between grade 0, no emphysema, and all other grades, grade 1 and until 5. And the second component of the loss then discriminates between grade 0 and 1 on the one hand, and 2 to 5 on the other hand, and so forth. This model performs very similar to trained observers, just in reproducing the visual score, as you can see here in the ROC curves. So this is an ROC curve. If we have no or random discrimination, you would expect to see the 45-degree line. Perfect discrimination would go up vertically and then horizontally. What you see here that, so on the left you see the ROC curve for any type of emphysema detection. And I'm not sure if you can see it well. I can't actually on my screen. But here there's a little dot which indicates the agreement between observers. So the model performs exactly on par with the inter-observer agreement. On the right, you see ROC curves for discriminating between different other grades, and you see that performance deteriorate if we go to the higher grades, for instance, between grade 2 and 3. The model does not perform that well anymore, but also the observers perform equally poorly. And if you go back to what it means, grade 2 and 3, grade 2, about a quarter, well, up to a quarter of the region is affected. Grade 3, between a quarter and 50% of the region is affected. Humans are just not very good at eyeballing disease extent in this way, and there's a huge inter and intra observer variability. So here's some results in more detail. The proportion that so you see here the results compared to, so this is our proportion that try to estimate the right proportion of emphysema, where we compare it here to a global average pooling net, which only tries to predict the visual score, but without knowing that it is, without using the knowledge that it is actually a proportion and should be between these percentage cutoffs. And we see that the proportion net, it it has the advantage that it provides a segmentation, of course, but it also performs better than the regular regression network, which also optimized to predict the correct visual score, but does not encode this knowledge. And the difference between these two models is especially pronounced in the case of smaller training sets. So that's where this prior knowledge on the nature of our labels really helped the optimization. So we have no ground truth segmentations of emphysema available. We did a small check to see whether the segmentations that were found made sense. What we do have is that radiologists labeled the emphysema type in paraseptal, which is typically, well, it's located around the surface of the lung or between lobe boundaries, and centrilobular, which is in more located in the middle of the lobe. So we evaluated whether the segmentations that we found were in the paraseptal or in the centrilobular region, and then used that to detect the emphysema type. And we found a very good agreement between this detection based on the segmentation and the radiologist scores, indicating that the segmentations indicate the right regions in this case. I was wondering if I would skip this, but I do think we have plenty of time today. I hope you are still staying awake over there. Well, let's show this briefly. Can we do without expert annotations? So emphysema scoring is notoriously difficult, also between trained radiologists. There is a huge disagreement, as we saw, especially in the visual scoring, in the higher degree scores. But what might be easier for humans to do is to assess which two images are more similar from a set of three. And we assessed whether whether non-experts can do this, and whether the models trained on that actually provides helpful information for quantifying emphysema. And if that works, we could simply obtain annotations by crowdsourcing. So we have non-expert observers indicate which of these images are similar, and then learn a triplet embedding based on these visual similarity scores. And such embedding was found to be useful for emphysema detection. I don't think I have the detailed results here, but models obtained by crowdsourcing, they were not as good at learning from experts, but they were promising. And we think models trained on a combination of smaller expert annotated datasets regularized by a larger crowd annotated dataset could be quite useful in this case. Another option, as I mentioned briefly before, is to learn from disease outcome labels directly. And on this very large lung cancer screening dataset, we do have disease labels and disease progression. Disease progression was measured as well. What we did was we trained a machine learner to discriminate between images of screening participants with and without COPD. And the advantage here is that our machine learning may pick up on other patterns that are important for predicting COPD that our radiologists have not yet described. So can CT pattern predict disease more than a radiologist can, and in this case, visual scoring or densitometry? Now, these are the COPD, these are the ROC curves for COPD detection based on a machine learning model. This was actually not a deep learning model. It's a little bit older work, but quite similar in nature. And you see here ROC curves for discrimination of COPD by machine learning on the left and by two different standard densitometry measures on the right. You see that the machine learning model finds fairly good discrimination, whereas classical densitometry measures can only recognize the most severe stages, and they're pretty random in recognizing the milder COPD cases, so they can't do early detection. Here's another view of that. So here's an example where machine learning finds patterns that predict disease better than known radiological measures, even though it was trained only to discriminate on between COPD and non-COPD. Our method can also discriminate different stages of COPD. You see here from the bars from left to right, no COPD, mild, moderate, and severe COPD. And you see that the machine learning method finds a nice trend here, whereas the densitometry can only recognize basically this most severe COPD. It can't do mild COPD prediction. And even though the model was only trained on recognizing current COPD, it was not trained for staging, and it was not trained for disease progression prediction. It could also predict future development of COPD, whereas densitometry could not. And we expect that if we would train it to predict future development, it might be even better. So far we've seen examples of cases where labels are weak, in the sense that they give less information than dense voxel-wise annotations. Now, what if labels are just bad? Typically, that's actually much less of a problem, I think. So many people would say garbage in is garbage out. Careful data curation is extremely important. If your training data is not accurate, you will never get a good result. Well, to some extent that's true, but I think this image beautifully illustrates that if you treat garbage the right way, you can still get a very nice end result. Here are just two examples where training data, as in the top row, was not very good, with very noisy segmentations on the left and very incomplete segmentations on the right, but segmentations from a model trained on this data, as given below, are actually quite good. Annotations don't need to be perfect. Random noise can be averaged out. Many weak labels are typically better than a few strong ones, and many noisy labels are typically better than a few perfect ones. So if we have to choose between collecting more data or collecting better annotations, I would go for collecting more data with weaker annotations. Finally, I wanted to show you a little bit of this topic as well, adversarial attacks, but I'll try to keep it brief to also have enough time for the discussion. So it's well known that neural networks can be fooled. So here you see an example of that. You see here 3 different images that were all correctly classified, correctly recognized by a model. Now, if you add a little bit of noise, if you add a little bit of noise in such a way that to our visual system, these images still look the same, the network is suddenly very certain that all these images are an ostrich. So networks can be, or images can be altered in such a way that you don't really see the difference, but a network would predict a completely wrong result. And this holds, of course, for medical imaging as well. Here's just one example of a former PhD student in my group who manipulated this X-ray image such that the heart segmentation looks recognizable, but quite incorrect. Of course, in the case of segmentation, this may not be really a problem because it's easy to check if segmentations are wrong, at least by experts. But if AI would be used more as a black box without explaining the decisions, just giving a decision, giving a diagnosis, this might be more dangerous. It's important to realize that the noise that is added here, it's not random noise, it's a very specific perturbation that is related to the gradient of the loss with respect to the input image, so that the model is tricked to give the wrong answer. And this means that attacks work best if the attacker knows the exact model parameters. And if not, the attacker can train a model, a similar model, a surrogate model, and attack that model. And it is known in many examples that attacks do transfer between models. Now, is this really a problem in medical imaging? I'm not sure, actually. So, of course, we already assume that an attacker has access to the images, where so an attacker would already be inside the hospital system if we're talking about hospital medical images, MRI scans, CT scans. And in that case, it might be much easier to just change the diagnosis in another database rather than manipulate the images. It's also maybe not trivial, or often you can check whether an image has been manipulated with, whether it has been tampered with compared with the original CT scan that came out of the scanner. But anyway, let's look at what could be a realistic attack scenario given that the attacker has access to the images. We assume that the perturbations should be not easily observed. Otherwise, if it's obvious that the image has been tampered with, it could easily be detected. We assume that's not the purpose here. We think it's realistic that an attacker may not have complete knowledge of model parameters and may not have had exact access to the exact same training data that the model was trained on. And then we looked at different models and different attack performances in 3 application areas and investigated the effect of changes in model architecture, pre-training on ImageNet in this case, and the effect of training set sizes. And these are the 3 different tasks that we looked at: fundus imaging, X-ray imaging, histopathology. Fundus imaging, it was to detect diabetic retinopathy. Chest X-ray imaging, detecting, so it's the chest X-ray 14 database detecting 14 types of pathology, and histopathology, detecting the presence or absence of metastatic tissue. And here you see some results on the effect of pre-training. First, we're going to look at black box attacks here. So the model, the attacker does not have access to the exact model parameters, but it does have access. It does use the same architecture and training data. So let's look at this case. So in the top row here, you see if there's no attack, the results that are shown here are area under the ROC curve. So a low number means that the attacked model performs poorly and the attack was successful. The top rows show the results for models that are not attacked with or without ImageNet pre-training. First of all, it's important to note that the performance of all models does really drop dramatically when they are attacked. And this drop is even larger when they were initialized in the same way. So if the model was pre-trained on ImageNet and the attacker, the surrogate model, was also pre-trained on ImageNet, then performance is as low as 0% in some cases. But if only the initialization of the model is different, then already the performance of the attacks is a lot less. But still, the model performs less good as it did initially, before attacks. Now, when the architecture of the target and the surrogate are different, attacks are much less successful. They still drop in performance in most cases, especially when both models are pre-trained on ImageNet, as you see here. So there are still quite poor performances. But here on the bottom two rows, you see the models where the architectures of the model that is attacked and the surrogate model are slightly different, and also the initializations are different. Then model performance still maybe not exactly the same as before, but gets better. And now that was important to note, it's still models that are trained on the exact same training data. Now we look at differences in training data. So first row again shows no attack, and then we're looking at cases where the architecture is the same, training data in the first row is different in the let's just point at it. Here we have the same training set. Here we use different training sets. In all cases, if the attack and the original model are trained on the same data, attacks are much more successful. And then when architectures are different, this effect is less clear. When both architecture and training data were different, but they're still a subset of the same data, so they're very similar properties, they're just not exactly the same images, attacked models keep around 80 to 90% of their original performance. And that is when only slight changes in the architecture and training data are made. So, to conclude in this part, black box adversarial attacks can be successful, but much less so if training data and model architecture are known. Pre-training on common data may dramatically increase model vulnerability, even when the target and surrogate architecture are different, and even when the target and surrogate use the same training data. So, take away from this is, in many cases, your model, your images will not be easy, will be secure, will not be easy to tamper with, and then vulnerability to adversarial attacks will not be a problem. In cases where adversarial attacks should be considered, it may be useful to not disclose model parameters exactly, and to not rely solely on pre-training or on training on large public datasets. To conclude, there are many ways to reduce annotation workload for model training. Machine learning is very successful, but there are still many open challenges. Brute force learning is in many cases not the best. But there are many ways of introducing prior knowledge in learned models, and many ways to reduce annotation workload. In some cases, direct prediction of weak labels may be better than first estimating strong labels as an intermediate step. We have talked a lot about segmentation or detection tasks, and that is often not the end goal. Biomarkers, for instance, the volume of certain structures or the risk of disease progression. In that case, direct prediction of such labels may sometimes be better. Thank you for your attention, and I'll be happy to answer any questions.
Thanks very much, Marleen, for this very, very interesting talk. We have time for questions from the audience. Yes, there are some questions in the back.
Oh, yeah. Okay, thanks for the very nice and informative talk. Like in one of the, I guess, first examples, you showed that your model was quite close predicting the, I think it was the coronary artery diameter compared to the ground truth and a fully supervised approach. But I noticed that in one of the slides, yeah, that one, in the central slice, the shape was very similar, but the diameter was not. So my question, I guess, is when a good result is actually good enough in a clinical case? Because maybe would the clinician change the, I don't know how to say it, but like the diagnosis based on the difference in diameter? If that makes sense, of course.
Yeah, that's a very valid question. So this was still early work, and we also want to evaluate what is really the measured stenosis by the clinician, and to what extent can we predict that based on our current segmentations. I do think our model has a slight preference because it is supervised on the maximum diameter and looks for piecewise circular shapes. It has there is a tendency to, if the shape is not circular, to shrink it a little bit. I think clinically, actually, this would not be a huge problem because the very strange shape, they happen in the bifurcation area of the vessel, as you see here in the middle slice. And that's not where the largest plaques are. They are just above the bifurcation where the shape is. They would be circular, slightly oval, but not very different. But there's room for improvement, for sure.
Yes, we have one more question. 1 second.
Thanks for the great talk. I have a very pragmatic question. So if we think about weakly supervised learning or semi-supervised learning or any kind of other data-efficient learning, the question arises, when do we actually go for this type of a technique? Because if we think about the net cost of a grad student per year, that equates to about maybe 450 to 550 hours of radiologist time per year. So clearly there are applications where you cannot really solve, for instance, in 3D segmentations when they are like complex structures. Even with 500 hours, you probably can never acquire enough data. But how do you actually, in your opinion, in your expertise, you have done a lot of amazing research, how do you actually decide when do you go for data efficient learning and when do you just brute force the problem with annotations?
So if I have a clinical collaborator with a very concrete problem, fairly standardized data set and willing to invest time in annotations, I would go for fully supervised learning. That's to get an initial result. I think that's the better trade-off. But so it's not only, so to get a reasonable segmentation result that can be used in the clinic to some extent, we may not need that many data sets. But to get a really reliable result that is transferable, applicable to many different scanners, scan types, I think we need to be very careful of this this bias, this unknown correlation between image properties and patient properties, disease properties. So I think we do need to regularize our models. So I think this is helpful in the bigger picture, whereas maybe for every single problem where you need results quickly, the easier way would be to go for fully supervised learning. Does that make sense?
Yes, certainly. I'm I'm in favor of actually using both at the same time. I think we need to use both the prior and the data, because
Yes,
that's how it goes from the Bayes rule. But it feels like our field needs some sort of a guideline, maybe like how industry practitioners could actually utilize these techniques and when. I think this is something that's missing, and that's what I was, I guess, asking for.
Yes.
Yeah, Marleen, this is Jerome. Thank you very much for the brilliant talk. I have a question, maybe that's a bit related to that, but because of my level of incompetence in machine and image analysis, I've not been able to grasp. I'm struggling a little bit with the fact that, so you use, my understanding is that we use then the manual segmentation as ground truth. And then when we have high inter-observer variability, for example, you've shown a case in the brain where inter-observer scores were 0.62, 0.75, which are not great. And then, so you're applying the learning process and then the automatic segmentation process, right, this slide. And then you come with index of 0.8 plus. So I'm really wondering, so if the ground truth is not robust, so how can you really improve then something? So, and then derived from this question is, would it make sense to have an error propagation model, so going through the learning model, and then so having different options then to choose, and be sure that you're actually reducing the inter-observer variability based on different models that would result from the training that would be then submitted to the inter-observers. I don't know if it makes sense at all.
So the first point, how can you improve on, if your ground truth is not very good, how can you improve on that? Well, so maybe I want to highlight again this one a little bit. So in some cases, if the errors in your ground truth are pretty random, but you have many examples, you could expect that such errors are averaged out in your final result. And then your result can actually be, your model can give a more stable, more reliable result. In many cases, the inter-observer agreement is much worse than the intra-observer agreement. So an observer can, there's some variation of course, but they make similar decisions each time, but they just, between observers, they don't agree on where exactly the structure is or how large exactly it is, or even what type of structure it is. And that is, such bias is more difficult to deal with. So that, yeah, the ideal case would be to collect results from more observers and use that to train your models with either consensus readings or with a combination of the average of the results of different observers, or just put the same training image with different ground truths in your training and learn all possible solutions. So that was the first part of your question. The second part, I already forgot something on error propagation, but can you help me here?
Yeah, exactly. So if you have a high variability on the ground truth, so then taking into account this variability into the training, and then have as an output, so not only one output that averages out the possible errors, but maybe you can have then 3 different outputs that you submit actually then again to the expert and see if you achieve better agreement on one of the 3 solutions, for example.
Yeah, so I think that's similar to, in your training data, obtaining consensus between different experts. But the key difference here is that you could apply that on a larger test data and have observers check these results and approve them. And that in general, this iterative model building could be a good way of increasing your data set, with the caveat that you might be propagating errors because you give the observer, you give the expert a biased set of data, and they may be, if it's not exactly correct but close to correct, they'll probably say it's correct, rather than in a segmentation example start correcting every single voxel. But we have in such an iterative manner collected training data in, for instance, to transfer a model to a new scan protocol. We have updated our training data this way, and it's a quite practical way to get good results.
Okay, thank you.
Any more questions from the audience?
Thank you. I would like to ask you one question about the COPD case that you showed. Yeah, indeed, the spirometry test is what is in the guidelines as well to assess disease severity, and it performs the way it does. But do you think, is there any way you can use also other sources of data to inform your segmentation model, or such as, for example, we know that mobility monitors can give us an information about the quantity and the quality maybe also of the walking of those people. And we know that patients with COPD may walk less or differently when the severity increases. So could you potentially combine also any of those quantification of mobility into your models to tune it somehow, to inform it?
I haven't thought about that. It's an interesting thought. So I am in favor of, as one of the previous people who asked the question also posed, I am in favor of combining different types of information in training, so strong and weak labels. What I've shown are what happens if we train only on visual score, what happens if we only train on lung function, what happens if we only train on segmentations. I do think it's better to combine them typically. I don't think I would go as far as, so I would like the information that we combine to still be related to COPD and the image itself, as long as we're going for segmentation, right? So then I would not go as far as to include data from wearables. But thinking about disease progression and well, general health prediction, therapy prediction perhaps, it makes a lot of sense to combine that kind of information as well.
Okay, so I have
just for segmentation, probably not.
So I have a question that is related to this, actually, because I was thinking about the same stuff. And of course, nowadays, there's a big push towards multimodal data fusion in the context of language embeddings and how to incorporate all the kind of medical history or whatever other type of knowledge into, so not just image analysis, but more like, in general, patient care AI systems, right? So I don't know what's your view in that, in mixing like multimodal learning with embeddings of different type of information. I don't know if you have explored some language image multimodal analysis or.
I have not explored language image multimodal analysis myself. I do think with the current status of language models, it's a no-brainer to take this kind of information more seriously and start incorporating it in our models. I do think combining different types of information is the key, not only to reach a better diagnosis, but also to reach a more reliable image analysis results. So if we are training on large data sets, but there is this hidden correlation that, well, even if it's just only patient age, people who are much older have a larger risk of developing Alzheimer's disease. But that's, if you train a model to predict that, it may be just looking at the ventricle size and general signs of age rather than signs of disease. And if we take this kind of patient information also into account in training our models, we can build more reliable models that are less dependent on these confounders and therefore more transferable between data sets and give more less biased, more safe, more fair results.
Mm-hmm. So I very much agree with what you said. I don't quite agree with the fact that, I mean, it's true that the current state of technology and of models allows to have early results very soon, right? So we could build a model that is multimodal with language mixing different type of information and get something out and publish it tomorrow. But I think this necessarily will push us towards thinking of information in a structured way again, and not just putting everything into a bag and learn. But I don't know. I think. Do you think this? Because in the end, there are consistency issues, right? So when you have a weak label that is a diameter and another one that is a radius, they are related, right? Conceptually, and you have to learn these relations. When you have clinical data from clinical history and medical images and blood tests, there are relations, and there are huge communities that have been working on ontologies and things like that, and more like symbolic AI for forever. And I think this necessarily will push a bit towards marrying and or getting together these communities at some point, doesn't it?
Yes, definitely. And maybe to clarify, I think we should incorporate, I think we should do multimodal learning. I'm not necessarily in favor of black box multimodal learning. We should keep on thinking about what our measurements mean and how we can incorporate them, and which labels are more important than others if we, for instance, use the language model to derive labels for training.
Thank you. And just one very final question. So, of course, this is a summer school, and there's a mixture of profiles. Some of them are kind of junior profiles that are thinking about where to go in their careers. And we are asking everyone that presents a bit their perspectives or their recommendations, or a bit, based on your experience, what sort of fields, or what's a bit your experience in working in interdisciplinary environments, like yourself, you work in Erasmus Medical Center as well. And it's a very open question. I don't know if you can give some remarks or... Yeah.
It's maybe too open for me at this stage. Yeah, so I think it's really exciting to work at this intersection between fields. I'm not sure actually what, probably in your institute you have the same, that you can work quite closely with technique developers and clinicians. Yeah, so I think the nicest research that we've done is when a real clinical question and a real methodological insight come together. For instance, my PhD student, Robin, who recently did the work on learning from diameter annotations, he was going to do something with weakly labeled learning, but just by being embedded in the clinical department and having these discussions, seeing that these annotations are made and what are the problems with them, that really inspired him to use his more mathematical view to solve that problem.
Okay, so with those...
So try to find common ground between the two fields.
Okay, so with those closing remarks, I would like to thank you very, very much for making yourself available and for the great talk. Thank you.
Thank you for having me.